Tony, tell us a little bit more. Manuel told us a bit about the STAT3 inhibitors. You've been very involved with this program. Tell us about that.
Yeah, so this relates to an agent, and there's a group of agents that have been developed, but specifically in pancreas, an agent called BBI-608, which is at least presumed to be a stemness or stem cell inhibitors, but it's primarily a STAT3 inhibitor. And
wait, tell us what in the world is a cancer stem cell?
So, that's a very elusive element, and I'm not sure, that we still understand really what those. But those are supposed to be the hardiest, the most stubborn cancer cells that essentially are chemo-resistant, radio-resistant. I mean, resistant to any effectiveness. They're actually the minority of cells at the beginning, but there's an interesting component, and that's those cells that exhibit some stemness-like features. And those, essentially, when you push with chemotherapy, they acquire stem cell features, and those ultimately become the bulk of cancer cells, that as we progress from one line to the other, those are the cells that end up essentially being the bulk of cancer, and that's why we end up with less and less likelihood of hitting those. At least that's one hypothesis, of being able to affect cancer with further chemotherapy, when at the beginning we have a good response, eventually we'll lose that response. So the whole concept of stem cells and some stemness is a bit more dynamic than the rigid way we thought about stem cells. We had stem cells and we have the rest of them. Now we think we have stem cells, we have some that exhibit stemness-like features, and then we have the cells. So this agent is at least preclinically was shown to block the stemness features, sensitize cancer cells to the effects of chemotherapy, specifically taxanes and gemcitabine, but also to others. And we had a phase 1b study that was presented at multiple times, but at ESMO GI in its final form. In the evaluable patients, there was about 55% response rate. I mean, the waterfall plot looked very, very impressive, and so that led to a phase 3 study with gemcitabine, nab-paclitaxel plus minus the BBI. It's one of the largest studies probably in pancreas cancer, more than 1,100 patients, but it does have 2 stopping first around 200 patients, so the patients will be assessed as we go. But the study is really one of very few, unfortunately, in the field phase 3 studies that are bringing some novel agents into pancreas cancer. So until, of course, we have the results of the study, this looks promising, like a lot of other agents that look very promising, but the ultimate test will be the results of the phase 3 study.
And probably the other large phase 3 study that's ongoing right now is looking at hyaluronidase. Ramesh, tell us a little bit about this. This study has been plagued with some issues, but is now pushing forward.
Right. I think I've been the cause of some trouble here for the study, being the PI for the SWOG study with FOLFIRINOX. So hyaluronin is an important part of the stroma, and tumors which overexpress hyaluronin, just like HER2 in breast cancer, it's a poor prognostic factor, but there are agents there's an agent PEG-PH20 that inhibits hyaluronin, degrades the stroma, and in preclinical models with gemcitabine, pre-treating with PEG-PH20 improved survival in mice, very impressive survival. So that led to a study with initially with gemcitabine and PEG-PH20, randomized study showed a benefit. That led to an industry-sponsored study of gem-nab-paclitaxel plus or minus PEG-PH20. So that study has been presented recently, and for the PEG arm, overall did show improvement in PFS response rate, and in the 30 to 40% of tumors which had high hyaluronin also showed a improvement, and that's a phase 3 study, HALO 301, and it's one of the only biomarker-driven study currently. All patients need to have HA high by immunohistochemistry. So in parallel, SWOG did a study with FOLFIRINOX, assuming that PEG-PH20 would work with any backbone. And at interim analysis, there was no benefit, and the study was closed prematurely, that PEG-PH20 with FOLFIRINOX did not show an improvement.
Now, the HA high patients, though, that subset, have you divided that out
Not yet. So it's important to note that the PEG pH20 dosing was less. With FOLFIRINOX, PEG pH20 caused more toxicity, that you had to use less, and it's an unselected population. So just talking about negative studies, I think that's a huge lot to learn, because we have this agent with two different backbones showing very dissimilar results. So obviously there's a mechanistic effect here.
And we also learned that for this particular drug, we need to give some low molecular weight heparin
Correct.
to these patients as
very
well.
importantly, this was not found in the phase 1 study, that in pancreatic cancer causes more thromboembolic events. Also, this drug causes musculoskeletal events where you had to give prophylactic steroids.